I'm Antoni Chan. I'm consultant rheumatologist from the United Kingdom, and I'm reporting here for Room Now at EULAR 2022 in Copenhagen. And I'm giving you an update today on important topics in the field of spondyloarthritis. And I want to highlight a few important abstracts. The first one is in the field of psoriatic arthritis. We know that in the field of psoriatic arthritis, one of the issues is about the conversion of patients who first have psoriasis and then the later development of psoriatic arthritis. So in the oral presentation 0029 by Grobelski and colleagues, this question was being asked. So traditionally, a dermatologist would see these patients first when they have psoriasis, and we do know there are certain features such as nail involvement and scalp involvement, which may predispose them into getting psoriatic arthritis at a later stage. There are questionnaires such as the PAS questionnaire that are used to try to identify earlier these patients who may develop the arthritic component of psoriasis, but they are not as specific or sensitive. And therefore, in this study, they did something very novel, was they trained the dermatologists to use ultrasound, handheld ultrasound, to see if they could detect psoriatic arthritis earlier in patients with psoriasis. In the study, they had 140 patients with psoriasis who they assess and then later was confirmed whether they did or did not have psoriatic arthritis by the rheumatologist. So the interesting finding is that before the ultrasound, the sensitivity was 81% and the specificity 55% of these patients having psoriatic arthritis. After having a clinical evaluation and post ultrasound, the sensitivity dropped to 62%, but the specificity increased to 91%. So essentially, it is showing us that the targeted use of ultrasound improved the accuracy of the detection of psoriatic arthritis. It improved the referral rates and the accuracy of the referral that goes to the rheumatologist. So this could be something that we could adopt and use in our clinic on top of clinical assessment and questionnaires that we have at the moment. I thought this was very interesting, especially as we're trying to detect psoriatic arthritis earlier and treat it early in the patients who have psoriasis. Fatigue is another big issue in psoriatic arthritis. In this poster, in the oral presentation 0025 by Raman and colleagues, they looked at the data from the Discover 1 and 2 study. The Discover 1 and 2 study is the phase 3 trial of guselkumab, which is a IL-23 inhibitor in psoriatic arthritis. But they look in the aspect of fatigue. They use a score called the FACIT score, and which is a score from 0 to 52. And the higher the score, the less fatigue they had. And they look at the components as to what contributes most to fatigue. And they found that systemic disease, so having generalized systemic disease, contributed about 34% to the variability of fatigue. Next was joints. So you had joint symptoms that contributed 16% to the variation in fatigue. Next was skin involvement, which was 12%. But interestingly, in 39% of this study, they were not sure as to what were the factors that drove the fatigue. So these were the residuals. And again, this is a big area for research. Could this be biochemical? Could this be physical, psychological factors? That could also be important components that we could target in the future as we try to improve patients' condition by reducing the fatigue, as fatigue remains the number one patient-reported outcome on top of pain that patients have in terms of their day-to-day living. So a very interesting study. I think we need more studies into this whole area of fatigue. Another interesting poster was the whole idea of non-radiographic axial SpA and its progression to radiographic SPA, or what we call ankylosing spondylitis. And this is a 5-year multinational study. It's oral presentation 0149 by Podatny and colleagues. This is a 5-year study from the PROOF study, which was looking at how many patients progress from the non-radiographic form to the radiographic form, which is ankylosing spondylitis. We know that from previous studies, this is a huge range. Newly diagnosed patients, currently 20 to 80% of our newly diagnosed XPAR patients are non-radiographic, and 8 to 40% of them would progress to the radiographic form over 2 to 10 years. But this is from surveys and population studies. But the proof study was a study of 2,633 patients, and they looked sequentially at over 5 years how many progress, and 16% of patients progress from a non-radiographic to a radiographic form in 5 years. The mean time to progression to radiographic was 2.4 years. So this gives us an understanding of perhaps there are certain groups of people where we could consider more targeted therapies. And who are they? These are male patients, so the male gender predisposed to quicker radiographic progression. If they had good response to NSAIDs at the beginning, suggesting a more inflammatory type disease in these patients, and also the presence of HLA-B27 predisposed to this quicker progression to radiographic forms. So this is another area for research, another areas that we could target with more advanced therapies, but also to study the other group which didn't progress as quick, because there also might be factors there that could help us to understand this whole concept of radiographic progression. So I think these are the three abstracts and posters that I want to share with you from EULAR 2022 in Copenhagen. And thank you for your attention. I'm Antoni Chan reporting for Room Now.